By the end of this lecture, you should understand the practical management of traumatic brain injury, particularly the importance of resuscitation and the management of raised intracranial pressure, and of status epilepticus. A 32-year-old man is admitted unconscious with a head injury after being assaulted. How should we manage him? Neurological injury can be subdivided into primary injury, which is a direct result of the injury and cannot be modified, and secondary injury. The main aim of management is to prevent secondary injury. Secondary injury occurs as a result of inadequate cerebral oxygen delivery or as a result of herniation of the brain. Failure of cerebral oxygen delivery can result from systemic failure of oxygen delivery due to shock or respiratory failure, or due to intracranial pathology resulting in decreased cerebral perfusion pressure and therefore cerebral blood flow. The three main priorities in the immediate management of patients with severe blunt head injury are therefore resuscitation, prevention of herniation, and rapid diagnosis of the brain lesion. As a result, initial attention should be to the ABCs. Apnea, cyanosis, hypoxia, and hypotension are all associated with poor outcome. When manipulating the airway of a patient with head injury, remember the possibility of an associated cervical spine injury. The modified jaw thrust is a useful method of opening the airway without exacerbating any cervical cord lesion. Give high flow oxygen, and if the patient's breathing effort is insufficient, use bag mask ventilation to ensure adequate ventilation. Although most comatose patients require intubation, this does not need to be carried out immediately, provided that adequate ventilation can be achieved spontaneously or by bag mask ventilation. It is better to wait for a practitioner who is experienced in intubation, provided such a person is rapidly available. Resuscitate patients to a mean arterial pressure of more than 90 millimeters of mercury to ensure an adequate cerebral perfusion pressure, despite a raised intracranial pressure. Note that shock is rarely due to a head injury, except in young children, patients with medullary injuries, or patients with large scalp lacerations. Note that balanced crystalloids are relatively contraindicated in patients with brain injury, and normal saline may be a more appropriate resuscitation fluid. Following resuscitation, our patient has a blood pressure of 140/80, saturation of 100%, pH of 7.4, PaCO2 of 4.5 kilopascals or 34 millimeters of mercury, and a PaO2 of 30 kilopascals or 225 millimeters of mercury. He is paralyzed, sedated, intubated, and ventilated. His GCS was 6, and he was moving all limbs prior to sedation and paralysis. His neck has been immobilized. What should we do next? Although we suspect the patient may have raised intracranial pressure, neither mannitol nor hypoventilation are indicated at this stage. Mannitol should only be given prior to evacuation of any hematoma if there are signs of deterioration unrelated to systemic deterioration. This is because reducing pressure on the hematoma by reducing cerebral edema may increase bleeding due to a loss of the tamponading effect. It should also only be given after adequate volume resuscitation. Routine hyperventilation to a PaCO2 of less than 4.5 kilopascals should not be carried out routinely, as it is associated with a worse outcome. Sedation and neuromuscular block may be useful in facilitating transport and scanning of a restless patient. They may also be necessary to prevent coughing induced by endotracheal intubation. Coughing may result in prolonged rises in intracranial pressure in patients who already have intracranial hypertension. Although there are no data demonstrating superiority of any particular agents, it is preferable to use short-acting agents. A CT scan of the brain should be performed as soon as the patient has been adequately resuscitated and cardiovascular and respiratory stability have been established. Tranexamic acid, 1 gram over 10 minutes, followed by 1 gram over 8 hours, should be given within 3 hours of injury to patients with a GCS of less than 12 or evidence of intracranial bleeding on CT. Before we can transport our patient to the CT scanner, he develops a dilated left pupil, which is unresponsive to light. What should we do now? This patient requires very urgent therapy to reduce the volume of the intracranial contents. He is showing signs of herniation, indicating his intracranial pressure is already very high. At this pressure level, he is on the steep part of his compliance curve, and a minor increase of the volume of any space-occupying lesion will produce a catastrophic rise in intracranial pressure. Within the cranium, there are 4 types of tissue: brain tissue, space-occupying lesion, cerebrospinal fluid, and intravascular blood. Therefore, the only way of introducing intracranial pressure is to reduce the volume of one or more of these tissues. Neither the hematoma nor the CSF can be drained sufficiently fast to prevent the patient coning, so the only options are to reduce the cerebral edema with osmotherapy or the intravascular blood volume by hyperventilation. Thus, while mannitol and hyperventilation should not normally be used except in patients with intracranial hypertension refractory to evacuation of a space-occupying lesion and drainage of CSF, they should be used as life-saving measures in patients who are showing signs of herniation. Having stabilized the patient, the next step is to proceed to CT scanning. This shows a left subdural hematoma, and the patient is taken to the operating theatre for evacuation of the hematoma and insertion of an intraventricular intracranial pressure catheter. Following his operation, the patient is admitted to ICU. His pupils are equal and reactive, his mean arterial pressure is 80 millimeters of mercury, and his intracranial pressure is 26 millimeters of mercury. What should we do next? The priorities are to ensure adequate cerebral oxygen delivery and to prevent herniation. Achieving adequate oxygen delivery is dependent on the arterial oxygen saturation and the cerebral blood flow, which is dependent on cerebral perfusion pressure, which in turn is dependent on the mean arterial pressure and intracranial pressure. Of course, achieving adequate oxygen delivery is also made easier by reducing cerebral oxygen demand. In order to achieve these aims, the target should be to keep the ICP less than 20 to 25 millimeters of mercury, and having done that, to manipulate the mean arterial pressure to maintain a CPP of greater than 60. Having already removed the space-occupying lesion within the skull, the options to reduce intracranial pressure are to drain CSF using the intraventricular ICP catheter, to give mannitol, and to ventilate to a PaCO2 of 4.5 kilopascals, in that order. In addition, the patient should be positioned to maximize venous drainage from the head in order to prevent a rise in ICP as a result of impaired venous drainage, and hence increase intravascular cerebral blood volume. Cerebral oxygen demand can be reduced by analgesia and sedation, control of body temperature, and treatment of the cause of pyrexia, and prevention and treatment of fits. In addition, it is important to remember adjunctive therapy, such as stress ulcer and mechanical DVT prophylaxis, physiotherapy, treatment of coagulopathy, and prevention of hyperglycemia. Status epilepticus. This is a real emergency that needs to be treated urgently with the aim of stopping the fits or starting treatment for refractory status epilepticus within 30 minutes of presentation. The longer fits persist, the harder it is to terminate them, and the more brain damage the patient suffers. Initial management consists of the ABCs and correction of any hypoglycemia. If the convulsions are aborted, look for a cause and consider starting a regular anticonvulsant. If not, give lorazepam 0.1 milligrams per kilogram IV if the patient has IV access. Otherwise, give midazolam 10 milligrams IM. Lorazepam is more effective and has a longer duration of action than diazepam. If neither lorazepam or midazolam are available, give diazepam 0.2 milligrams per kilogram and then give phenytoin 15 to 20 milligrams per kilogram without waiting for any further fits, as the probability of further fits is high. If the first-line agent fails, the probability of the patient responding to a second-line agent is small, and therefore the next step is to treat the condition as refractory status epilepticus. If there will be an unavoidable delay in starting treatment for refractory status epilepticus, it would be reasonable to give phenytoin while waiting. The first step in managing refractory status epilepticus is to perform a rapid sequence induction and intubate and ventilate the patient. The most appropriate neuromuscular blocker depends on the situation. Succinylcholine has the disadvantage of causing hyperkalemia, which may be a problem in a patient who is already hyperkalemic due to rhabdomyolysis. Rocuronium has the disadvantage of a longer duration of action, which may mask continued convulsions. The next step is to start an infusion of midazolam, propofol, or thiopentone, titrated to abolish clinical and electrical seizure activity. Do not titrate drugs to produce burst suppression on the EEG, as some patients continue to convulse despite burst suppression, and other patients do not convulse despite failure to achieve burst suppression. Furthermore, midazolam does not produce a burst suppression pattern except in neonates. Give a loading dose of 0.2 milligrams per kilogram, followed by an infusion of 0.1 to 2 milligrams per kilogram per hour, but be aware that tachyphylaxis occurs and a significant dose increase may be required after 24 to 48 hours to maintain seizure control. The recommended dose of propofol is given on the slide. It's important to be aware of the possibility of propofol infusion syndrome if high doses are given for a prolonged period of time. This syndrome is characterized by severe metabolic acidosis, rhabdomyolysis, and cardiovascular collapse. Okay, before our final summary, I would like you to write down 3 things you learned from this lecture that you think are important messages. Perhaps things you would tell a colleague who missed the lecture. The key points related to head injury are resuscitate first, maintain a cerebral perfusion pressure of more than 60 millimeters of mercury, reduce the ICP with evacuation of the space-occupying lesion, drainage of CSF, mannitol, and ventilation to a PaCO2 of 4 to 4.5 kilopascals. Sedate the patient, nurse him or her head up, prevents fits and fever, and prevent hyper and hypoglycemia. Key points related to status epilepticus. It's a true emergency. Check for and treat hypoglycemia. Give lorazepam 0.1 milligrams per kilogram. If that fails, sedate, intubate, and ventilate, and start a thiopentone, propofol, or midazolam infusion.